Very good morning to one and all. I'm Dr. Sanmugapiriya. Today's topic for your class is pulse oximeter. So, what is a pulse oximeter? Where it is used? Any idea? Yeah, day to day in OT, and once the patient got admitted in the hospital, to assess the saturation, we will be using the pulse oximeter. Yes. So, moving on to the introduction. It is the fifth vital sense and one of the non-invasive method for measuring the hemoglobin saturation. The main operating principle used in our pulse oximeter is it has a combination of two methodology. One is spectrophotometry and the optical plethysmography. So what is the spectrophotometry? It usually measures the hemoglobin oxygen saturation, whereas the optical plethysmography, it measures the pulsatile changes in the arterial blood volume at the sensor site. So it has a combination of two technology, mainly the spectrophotometry and the optical plethysmography. Spectrophotometry, or yes, it measures the oxygen hemoglobin oxygen saturation, and the optical plethysmography, it measures the pulsatile changes in the arterial blood volume at the sensor site. See, this is the electrode, that is the SpO2 probe. It has the two diode. One is red and the infrared. What is the range? Red waves absorption is 660 nm and the infrared is 940 nm. And we are having one detector and one optical cover is present so that it covers the finger, and one cable through the cable, and the cable is connected to the monitor. So the main parts used in our SpO2 probe is it has a photo detector that is kept in the pulp of the finger, whereas the two diodes are kept in the nails. So it has the red and the infrared combination, 940 to 660 range. So moving on to the Beer-Lambert's law. The intensity of transmitted light decreases exponentially as the concentration of the substance increases, and the amount of light absorbed is proportional to the concentration of the light absorbing substance. So this is more important. So Beer's law and Lambert's law. Of this, Beer's law, the intensity of the transmitted light decreases exponentially as the concentration of the substance increases. Okay. And also the amount of light absorption, that is proportional to the concentration of the light absorbing substance. See, if there is a low concentration, see the red dot thing, where the concentration of the oxygen hemoglobin is low, then the absorption is also low. If there is a higher concentration in the blood, that is where the oxygen carrying capacity of the blood is high, then we can see the higher absorption rate. And moving on to the Lambert's law. The intensity of transmitted light decreases exponentially as the distance traveled through the substance increases. And the amount of light absorbed is proportional to the length of the path that the light has to travel in the absorbing substance. See, the less light path length, lesser the light path length, we are having the less absorption. Whereas the more light path length, that is, see the thickness, we are having more absorption capacity. So moving on to the formula, E is nothing but the base of the natural logarithm. E equal to IO into E minus DCA, where IE equal to is the nothing but the intensity of the transmitted light. IO is the intensity of the incident light. D is the distance that the light is transmitted through the medium. C is the concentration of the solute. Extension coefficient is a constant for a given solute at a specific wavelength. So E is the base of the natural logarithm, that is approximately 2.7182. So what is the wavelength our SpO2 probe is working? Red and infrared is 660 and 940. Okay, that is the wavelength absorption. So moving on to the oxyhemoglobin absorption is more if the infrared light is more than the red light. Similarly, the deoxygenated hemoglobin absorption is more for the red light than the infrared light. So this is the alternate. That's why the wavelength is of the absorption is 940 in the case of oxyhemoglobin, that is the red light, and 660 for the infrared light. Pulse oximeter is use a type of light source called as light emitting diodes. I'll be using this abbreviation LEDs, that is the light emitting diodes. If the pulse, that is nothing but it pulses the red and the infrared LEDs, which is on or off several times per second. So once it is on or off, we'll have alternate red and the infrared light, which is as the blood flows, we'll have alternate on and off of the red to the infrared transmission. Then the emission of these two wavelengths alternate at a frequency of 0.6 to 1 kilohertz. See, as I told, no, this artery and the vein, where we have the red light and the infrared. Then once the absorption, there is a light source, and the light source's detector is kept in the base. That is the photo detector. On the top is the both the electrodes, red and the infrared, and the finger which has the both artery and the vein. So this is the pictorial representation of our pulse oximeter with the hand on probe. Moving on to the plethysmography, that is we are having, systole and diastole. In diastole, the absorption of non-pulsatile arterial blood, venous blood, tissue and the bone. It is called as direct current component. Whereas in the systole, it is the pulsatile expansion of the arteriolar bed produces an increase in the path length and increase in absorption. This is called alternate current component. It is AC and DC, from your school days onwards. That is direct current and the alternate current. In systole, it is called as direct current, whereas in diastole, it is called as direct current, and systole will have the alternate current. See, both in the this is the graphical representation, that is the direct current and the alternate current. Alternate current comes under what? Alternate current is in systole. That is the in systole we'll have the pulsatile arterial blood waveform. Okay, whereas non-pulsatile are the venous and capillary and tissue, where the oxygen transmission is, even though it is used, but it is not visualized because SpO2 is monitor is a non-invasive, whereas invasive we will have the invasive arterial blood pressure, and in that we can monitor the blood pressure. Here it is a non-invasive method. The microprocessors can select out the absorption of the pulsatile fraction of the blood in AC from the constant absorption of the DC, thus eliminating the effect of tissue absorption to measure the oxygen saturation of the arteriolar blood. SpO2 determines both the red and the infrared absorption ratio, whereas red is to infrared ratio is the pulsatile difference that is being used to compute the pulse oximeter reading. So this is one formula, you just note it. SpO2 equal to, that is F into alternate current 660 bar DC. 660 by AC 940 by DC 940. The measured ratio is compared with the stored one in the microprocessor of the device and correspond to the SpO2 that is displayed in the monitor. Then moving on to the ambient light, that is the room light, where our OTs are in the other ward, we have the room light. That is also an hindrance to the absorption from the arteriolar waveform. Okay, the room light, that is the ambient light, is an unwanted noise. Our pulse oximeter even detect that, and that is also an artifact it will come. So to eliminate this effect of an ambient light, the pulse oximeter has the following sequence. Only if the red light is on, the sensor measures the red plus the room light. Only if the infrared light is on, the sensor measures the infrared plus the room light. If both LEDs are on, the sensor measures only the room light. So only the red light is on, now the sensor will measure both the red and the room light. If only the infrared is on, infrared, and if both the lights are off, the sensor will measure only the room light. So this is the pictorial representation of that. So moving on to the functional SaO2, that is the oxyhemoglobin divided by oxyhemoglobin plus reduced hemoglobin into 100%, whereas fractional SaO2 equal to oxyhemoglobin by oxyhemoglobin plus reduced hemoglobin plus carboxyhemoglobin plus methemoglobin into 100%. Okay. See our waveforms, anacrotic, and this is the systolic plus systolic peak, and once it slopes down, we'll have the diastolic limb. In diastolic limb, we will have the diastolic notch and the end diastole. So it has an anacrotic limb and the dicrotic limb. In anacrotic limb, it ends in the systolic peak, whereas the dicrotic limb ends in the diastolic peak. See, the anacrotic limb marks the waveform initially in the upstroke, which occurs as the blood is rapidly ejected from the ventricle through the opened aortic valve into the aorta. Whereas in systolic peak, what you will see, the arterial pressure is then rises sharply, resulting in the systolic peak. Then the waveform is the highest point. Whereas in the dicrotic limb, what is the dicrotic limb? As the blood continues in the peripheral vessels, the arterial pressure falls and the waveform begins a downward trend called as the dicrotic limb. Arterial pressure usually keeps falling until the pressure in the ventricles is less than the pressure in the aortic root. In the dicrotic limb, we are having the dicrotic notch. What is a dicrotic notch? When the ventricular pressure is lower than the aortic pressure, aortic root pressure, the aortic wall closes. You all know. This event appears as a small notch on the waveform. That is the downslide called as dicrotic notch. Then moving on to the end diastole. When the aortic wall closes, then the diastole begins the processing until the aortic root pressure gradually falls to a lowest level. This is and this waveform is known as the diastole, end diastole. So moving on to the types of the pulse oximeter. This is that it has two types, mainly the transmitted pulse oximeter and the reflected pulse oximeter. In moving on to the transmitted pulse oximeter, the emitter and the photodiode are placed in opposite to each other. Measuring the site is kept in between the two. As you all commonly seen in our ward and OT, we'll keep the finger and the pulse oximeter surrounds this. That is the photo detector is kept below and the emitter is on the nail side. So I have shown you the picture previously now. So this is the transmission pulse oximeter, and next one is the reflectance pulse oximeter. The emitter and the diode are side by side on the measuring side. The light get reflected from the emitter to the diode across the site. See, this is the so many models. This is the finger model, as you all seen, no? And this is the wrist model, and this is the handheld model, and this is the tabletop model where you can use the OT as a monitor. And these are all the equipments where the probe and cable and the consoles connecting the patient to the monitor. See, these are all the various models and the pictures. And this one is the pediatric finger probe. For the pediatric, they will be having very small fingers, small hands, and they have tiny, tiny, small butts. So for that, where the pulse oximeter is encroached and it has been tied. Whereas adult, it is like a finger clip on and off. See, we can tie so many sites. I'll come to the next slide. So, what are all the sites where we can use the pulse oximeter? Okay, you tell. Yes, what are all the sites you know? Yeah, you have seen the finger. Then, yes, finger, toes. Then, yes, nose. Hmm. Then any other site? So many sites are there. See, finger, toes, nose, ear, tongue, cheek, forehead, and esophagus. So there are 8 sites. So let's tell me it is the finger, toes, nose, ears, tongue, cheek, forehead, and esophagus. If some condition, if the patient is having any burns or in the burns affected the ear or fingers, we can use the alternate site. Moving on to the uses. So uses of the pulse oximeter is main thing, as you all know, monitoring the oxygenation under anesthesia and monitoring the oxygenation in PACU, guiding the severity of asthma. Grading the severity of asthma, diagnosing and managing the COPD, neonatal resuscitation, neonatal screening for congenital heart disease, CHD, prevention of hypoxia and ROP. So these are all the uses. So we have covered the sites where all we can place the pulse oximeter. Then the uses, main thing, monitoring the oxygenation, various disease where the oxygenation to the tissue is compromised. In that case, how much the compromisation of oxygen is graded using the pulse oximeter reading. Then moving on to the advantage of our pulse oximeter. It is an accurate instrument and it is a non-invasive one. We can continuously monitor and we can tone our modulation, and it's an user friendly. It separates the respiratory and the circulatory variables, and we have various probe varieties, and it is a battery operated and it is commercial. Okay, so these are all the advantage. So yes, tell me one by one. Yes, it is accuracy and it is non-invasive. You can continuously monitor the patient oxygen saturation, and we can tone the modulation, and it is an user friendly. It separates the respiratory and the circulatory variable, and it probes the varieties and battery operated, and it is economical. So then moving on to the safe limitation and potentially unsafe limitation. Safe limitations, under safe limitation, the limitation where the inaccuracy in displaying the SpO2 can be separated, can be suspected, and it causes recognizable. The device usually alarms and alert the observer about the problem, and there is an motion artifact. And if the patient is having poor perfusion, so that is also a problem in that, because as I told, no, how much the molecules are closely packed, we will have the that much variation. That is the oxygen carrying capacity. If they have poor perfusion, we can't assess the oxygen carrying capacity, and the waveform we can't get adequately. And skin pigmentation. And if there is a nail polish or any artificial nails, that will hinder it. And irregular rhythm. If the patient is having arrhythmias, we can suspect, we can note it in our waveform in the SpO2. So it all know that anacrotic notch, dicrotic notch. In that limb, we can make out the alteration. If there is any alteration, we can assess the rhythm of their heart. Then electromagnetic interference. So these are all the safe limitation. Potentially unsafe limitation. Limitation with the inaccuracy is difficult to recognize. The display of the SpO2 is incorrect, but there is no alarm, and warning to the observer can be a problem. Calibration assumption. Delay in detection of hypoxia. And probe position. Ambient light interference. And abnormal hemoglobin molecule. Venous pulsation and intravenous dye. These are all the potentially unsafe limitation. So in that, the main thing which interfere our SpO2 value is methemoglobin. So the normal ferrous, that is Fe2 state of an iron moiety, is hemoglobin is oxidized to ferric state, that is Fe3 plus. It absorbs the equal amount of red and near infrared rays. That is the two electrodes that we are taking. The ratio of pulsatile and non-pulsatile absorption in these two wavelengths is equal to 1 at the hemoglobin saturation of 85%. The higher concentration of methemoglobin causes the saturation to approximately 85%. So similarly, in the carboxyhemoglobin, it absorbs very little light of 940 nanometer, while the 660 nm is extinction coefficient is very similar to that of oxyhemoglobin. The presence of significant carboxyhemoglobin will resembles the curve of oxyhemoglobin in the red range, which is not effective on the infrared ray, as we look like oxyhemoglobin, causing the pulse oximeter to our reading. So here the carboxyhemoglobin plays a similar role like that of oxyhemoglobin. So we have a confusion. So for every 1% circulatory carboxyhemoglobin, the pulse oximeter reads the same 1%. See, this is the methemoglobin reading, that blue one. Whereas the oxyhemoglobin is the red one. And this is the reduced hemoglobin. Whereas this is the carboxyhemoglobin. So we should be highly suspicious, and sometimes we should look for the any poisoning effect. Hemoglobin of fetal and hemoglobin of S. These are all the sickle cell. Hemoglobin of fetal, that light absorption properties similar to that of adult hemoglobin. It does not interfere with the pulse oximeter. However, the abnormal hemoglobin molecules affect the ODC, and hence the oxygen tissue, that is tissue oxygenation, is also low, particularly for children with sickle cell anemia. So before going to the reference, a quick review. So what is the pulse oximeter? Yes, we should know what is a pulse oximeter and what are all the principles it works. So what are all the principle it is working? Yes, the two principle, that is the main thing, is Beard's law and Lambert's law. So this is the picture. Beard's law and Lambert's law, under this principle it is working on, and we are having the photo detector and the two electrodes which they are kept in the nail bed, so that we can assess the saturation using the pulse oximeter probe. And what are all the principle behind the Beard's law and Lambert's law, and what is the formula to calculate it? Yes, Someone can tell what is the formula to calculate it? Yes, E equal to IO to E minus DCA. Yes. Then what is the oxyhemoglobin and deoxyhemoglobin? Where it what is the wavelength you all know? And what is the light emitting diode? That is red light and infrared light. And the plethysmography. Once you have kept it won't show the number alone. It will show the graph. This is the graph. Absorption of light, and it is transmitted as a waveform in the monitor. So it has the mainly the pulsation is being transmitted as the waveform, and this waveform we can use it for the SpO2 monitor. It has the yes. See the picture. What is the waveform depicts? Arterial waveform. Anacrotic limb, systolic peak, dicrotic limb, where we have the diastolic notch. If there is any arrhythmia, we will have the variation in this waveform. If there is any variation in this waveform, we should suspect patient is having any abnormality in the heart rhythm. Then you all know what are all the types of the pulse oximeter. So, and we have seen the so many models used for the pulse oximeter. You all know finger model, wrist model, hand model, and the tabletop model. And what are all the connection between the patient to the monitor, and what is the cable, and what is the console, and how the probe is attached. And next one is site. What are all the sites? It's the 8 sites. So that is the finger, toes, nose and ears, tongue and cheek, forehead and the esophagus. So these are all the sites. And what are all the main use of the SpO2 probe is to monitor the oxygenation at various stages. One is during at the time of anesthesia, in PAC, in any acute respiratory condition like asthma, COPD, or neonates, their cardiac problem, or the patient is going for hyperoxia for prevention. So these are all the uses. And then moving on to the advantage. The main important advantage is, yes, still it's accuracy. Yes, very good. The next is a non-invasive one. Yes. The next is continuous monitoring and the tone of modulation, user friendliness, separate respiratory and the circulatory variables, and the probe varieties, and the battery operated one, and it is highly economical. So the most important one is what are all the safe and the safe limitation and the potential unsafe limitation. Our safe limitation is, yes, motion artifact. Yes. Yes, what? Poor perfusion and any nail polish or any artifacts in the nail. I told no irregular rhythms and any electromagnetic interference. Potentially unsafe limitation are whenever there is an intravenous dye or venous pulsation or abnormal hemoglobin molecule, ambient light interference, and probe positioning, delay in detection of hypoxia. There are so many things. Okay. Then moving on to the two important entity. What we have told, it is methemoglobin and oxyhemoglobin. Yes. Methemoglobin at least. Okay, but oxyhemoglobin, it shows the same 1% wavelength absorption is same as 1%. So carboxyl, it looks like oxyhemoglobin. This is the graph. And the last is fetal hemoglobin and the sickle cell anemia, how the hemoglobin variation. Usually fetal hemoglobin and sickle cell anemia, they usually does not interfere with the pulse oximeter. The main thing, abnormal hemoglobin will affect the ODC curve alone. Should remember only the ODC curve. If you are applying probe and you can ask whether this is a fetal hemoglobin or sickle cell hemoglobin, we can't detect it. Okay. Hence, the tissue oxygenation is low, particularly in the case of children and in sickle cell anemia. Only the ODC curve is affected, not the pulse oximeter. Okay. So these are all the references. Thank you.